Okay, yes, we are live on YouTube now. Rohini can start.
Hello, everyone, and welcome to the fourth keynote session of AMSACON. I am Rohini Datta. I am the immediate past regional chairperson of AMSA India. I am also the previous section editor for the Journal of Asian Medical Students Association International. And currently, I'm an intern at Christian Medical College Ludhiana and a researcher at the Indian Hub of Global Surgery under the NIHR University of Birmingham. As you join the call, I request you to kindly put your microphones on mute and switch off your videos so to avoid interrupting the meeting and also avoid interrupting the meeting by sharing your screen. Thank you. Now, as we start with this session, as you all know the topic, it's regarding global surgery research. I would like to brief you a bit on what global surgery is. For a very long time, surgery was not included in the discussion of how healthcare could be improved worldwide, especially in the most remote corners of Earth, including a low to middle income country like India. Only recently has surgery been brought to the table, being called the forgotten stepchild of global health by Paul Farmer and others. At the core, global surgery is a field that aims to improve health and health equity for all who are affected by surgical conditions or have a need for surgical care, with a particular focus on underserved populations in countries of all income levels. It is also important to note that under all these aspects of surgery, we must not forget including anesthesia, OBGYN, and nursing. Currently, 5 billion people around the world do not have adequate access to basic surgical care. Worse yet, the disparity in surgical care is stark, with the poorest 30% of the world receiving only 3 to 6% of operations, whereas the richest 30% receive almost 75%. So the bigger question becomes how we address this need for surgical care. In the past, this was almost exclusively involved through week-long surgical missions. However, the field has evolved with the creation of the Lancet Commission on Global Surgery, which encompasses almost 110 different countries. Efforts have now been set on working at the highest level with governments, ministers, and financial officers to improve people's access to surgical care. Ultimately, whether you're interested in surgery, anesthesia, OBGYN, global or public health, economics, finance, policy, technology, you have a very significant contribution to make in this growing field. And no matter how young or old you are, no matter how little or how much you can contribute, your involvement in global surgery is incredibly necessary and valuable. Now, I wouldn't have been able to get a chance to even know about this field had it not been for my extremely generous, professional, and versatile professor, Dr. Dhruv Ghosh. Dr. Ghosh is the hub director for the NIHR Global Surgery Research Collaborative, University of Birmingham, UK, for India. He is the professor for pediatric surgery at Christian Medical College, Ludhiana, Punjab, and he's the Indian consultant for pediatric urology at the Sultan Qaboos University Hospital in Muscat, Oman. Thank you so much, sir, for taking your valuable time in coming here to AMSACON for all us medical students. Sir.
Hi, thanks a lot, Rohini, and thanks for the generous introduction. I'm quite impressed. This is 154 people here. I don't think these many people ever heard me. So it's your bad luck today, guys. Thanks for everything. Rohini was being very generous, rather. I don't think we've really, as senior consultants, we've done justice to many of our medical students and interns and our specialty when it comes to research. If you guys are happy, and I can share my screen, and I'm grateful to Kushman and her team for inviting me here. It's an absolute honor to talk to medical students. I do not know much about AMSA India. It wasn't there when I was a medical student, but this looks very impressive. Very, very impressive. So can I share my screen?
Yes, sir.
Right. If you have anything to question me about either the end of the session or during the talk, I'm very happy for you to stop me at any point of time. Um, um, this doesn't have to be extremely formal. I'll start. So my name is Dhruv Ghosh. I'm a pediatric surgeon by profession and a pediatric urologist as my specialty in surgery. I trained at CMC Ludhiana for my MBBS and my general surgery a long time ago. And at the time when I was training, both in MBBS and general surgery training, there was nothing much about research, and especially nothing much about surgical research. The only bit of research that we had to do was to somehow complete our thesis so that we can go ahead and give our exams to clear our post-graduation. I went on to do my pediatric surgery training in Vellore and was lucky to work with one of my professors who was extremely interested in research, and that's where the bug was sort of planted in me. I went on to train in Australia for my pediatric urology, and I discovered a different world in the West where research was probably as important as your clinical work, and both of them went along. And that's where things started changing in my career. I presently lead the India Hub. It's a big honorific, the word hub director. I just am part of a team which does a fair amount of work now in global surgery and surgical research, especially related to India. And one of our objectives is to create sustainable surgical research platforms in low and middle income countries. There is a fair amount of research happening in high income countries, and as well as in countries like ours when it comes to medicine and allied specialties. But when it comes to surgery, we hardly do any work in terms of research. And you'll be very surprised to know that in my specialty of pediatric surgery and pediatric urology, there have been hardly any randomized controlled trials ever anywhere in the world. Rohini alluded to the Lancet Commission on Global Surgery, which was a defining moment in surgical research. And the Lancet Commission came out with this statement that about 5 billion people lack access to safe and affordable surgical care across the world. And a lot of those 5 billion are in countries like ours. If you look at the first map, you will see a lot of deep reds and oranges in countries like ours. This document was presented a few years ago, and I think things have not improved. In fact, have got worse since then, especially with the pandemic that is now encompassing the world. 143 million additional surgical procedures are needed each year to save lives and prevent disability. It's very sad that in 2020, in countries like sub-Saharan Africa, South Asia, and many parts of Asia, people are still dying of acute appendicitis, which is unheard of in the West. Along with that, the fact that we are not a very robust economy in most of the world where we work, about 33 million and more people face catastrophic health expenditure because governments are not able to provide for health in many of our countries, and therefore there is a lot of out-of-pocket health expenditure, which can be catastrophic and lead to starvation and worse in many of our countries. There is about a major deficit in global research in surgery in high-income countries. So about there is an 85% deficit in research and surgery in high-income countries. So in a country like United States or the United Kingdom, there is a huge deficit. So you can just about imagine what happens in low-income countries like low and middle-income countries like ours. I'll just take you back. Maybe some of you are still reading it. I'm not sure whether that, but when I was doing my MBBS, this is what we had to read in the community health book that was part of the curriculum. And we used to talk about the Bhor committee. Even now, the public healthcare in India is structured on the Bhor committee, which was actually constituted a year before independence. It's been 70 odd years since then, and we really haven't changed our healthcare structure. We were working on a 3 million plan, so there will be a hospital for every 3 million population. It was supposed to be a 10-year plan, so by 1956 we were supposed to get all this sorted. As you know, in countries like ours, this doesn't really happen. In British India, we had 0.24 beds per thousand population. By 1957, we were expected to have 1.03 beds per thousand population. And in the next 30, 40 years, say until the 1970s or 80s, we planned for 5.6, 5.5 beds per thousand population, which is fairly good. Unfortunately, this didn't happen. So our last reports, which came out in 2012, 17, and a little bit in 14, which you can access on the WHO website, is that we have 0.9 beds per thousand population. So if you look at what we were in British India and where we are right now in 2020, there doesn't seem to be a huge amount of difference when it comes to the healthcare that we have provided to our country. Worse and worryingly, there is only 0.63 doctors per thousand population, and that's in 2017. And for us as surgeons, even worse is that there are only 7 surgeons for 100,000 population. And when I talk about surgeons, I don't mean general surgeons only. I mean surgeons of all specialties. That includes OBGYNs, orthopedicians, etc. So there are only 7 surgical specialists per 100,000 population in our country right now. A large number of our hospital beds today are in the private sector. We seem to have given up a lot of our healthcare needs to the private sector. And if it hadn't been for the private sector, we would be worse off. So the private sector today has more hospital beds than the public sector. When we talk about hospitals, there are beds which are functional and beds which are non-functional. If you look at the public sector, it's about half and half, and the private sector seems to be doing slightly better at 70-30. But the thing to note is that most of these beds are in the top 20 cities, so tier 1 and maybe the good tier 2 cities. So you will have a lot of hospitals and hospital beds in, say, Delhi or Bombay. But you go back to deep, say, Bihar or even Northeast or even Central India, you will not find many hospitals or functional hospital beds. And that is worrying because even now, around 60% of our population is in rural India, or what we call urban rural India. That is the slums in our cities. For a country of more than 1.5 billion people, we spend very little on healthcare expenditure. It's only 3.9% of our GDP. If you look at the West with lower population, when I trained in Australia with a population of about 24 million in the entire country, they would spend about 30 to 40% of their GDP on healthcare. Healthcare being a major topic in countries like that. And they sort of, if you do not provide, the government does not provide good healthcare, it is an election issue and governments can be changed in healthcare. Unfortunately, that does not happen in our country. And this has been the scenario since independence. When healthcare expenditure, when I talk about the healthcare expenditure of 3.9% of the GDP is what the government pays to take care of your health and my health. Unfortunately, that is not enough. And we on our own have to sort of spend more than 70% from our pockets to take care of our health. And I'm sure many of you who have been, who've had the unfortunate occasion to spend on healthcare would have realized that a lot of it comes out of your own pocket. So 70% of our healthcare expenditure is out of pocket. If you take the country as a whole, about 7 to 10%, a little more now, private insurance penetration is there. So unlike countries in the West where almost everybody has healthcare insurance, in India, about 10% of the population has healthcare insurance, and that comes down further if you go into rural India. And to be quite frank, you will see a lot of doctors themselves do not have healthcare insurance. I'm not really sure how many of you in India have healthcare insurance, but I was surprised to see when in my department in CMC, there were about 3 consultants and none of them had healthcare insurance. Um, as I said, more than 60% of our population still stays in the villages, and we also classify the slums in the big cities also as rural. We call them urban rural because of the various facilities which are unavailable to that population, and which is a fairly large amount of population, especially for if you guys who've been staying in Delhi and Bombay, etc., would realize that. So there is an unequal distribution of facilities as well, because you have big, shiny corporate hospitals, what I call buildings of glass and steel, which are there in big cities, but you do not find them in smaller cities and in the villages of India, which is unfair because healthcare is something which is a primary need of a population. So what are our challenges? Our challenges are that we have deficient infrastructure, we have deficient manpower, we have unmanageable patient loads, we have a lack of equivocal quality of services. We have a problem with accreditation. Some of that has improved right now with things like NEET, etc. But there is a long, long way to go for us to have a uniform quality of training for all our doctors. And then there is high out-of-pocket expenditure. This is just a graph to show you what I had been talking about earlier. Most of our doctors are now in the private sector, and in the public sector there is a huge deficiency in doctors. What India has done well in the past 70 odd years is in terms of building tertiary care hospitals, and the graph at the bottom actually talks about tertiary care hospitals. And if you look at the various All India institutes and the medical colleges, we've done a fairly good job in building those and providing care. And that care is actually in many of our hospitals is extremely good and comparable to anywhere in the world, even better at times. We've done fairly okay in putting in our primary healthcare centers. So if you remember, in India, healthcare is divided into primary, secondary, and tertiary. The primary healthcare centers, which sort of gives vaccination, healthcare advice, taking care of antenatal visits, etc. Next comes in your secondary healthcare, which is your community health centers or the district hospitals, as we call it. And that's where is the point of contact with of a patient with a surgical specialist. Anything that cannot be handled there should be referred to the big hospitals like the All India Institutes, CMCs, etc. The system was made in such a way that the CHCs or the district hospitals would refer patients to our tertiary hospitals. So the tertiary hospital was supposed to be a referral hospital. And I don't know about a lot of our tertiary hospitals actually did not have emergency rooms or trauma centers to begin with, because they were not supposed to deal with those, and they were supposed to sort of just be referral hospitals. Unfortunately, we did horribly at developing our district hospitals. So the number of community health centers where a surgeon or an OBGYN or an orthopedician was supposed to be there never ever got off. And that has put a huge load on our tertiary hospitals. So if you walk into the All India Institutes, you will see crowds. And if you try and get an appointment, say in CMC Vellore, it'll take you ages. And that is because there is a failure in the system between the primary health center and the tertiary health center, and that is the secondary hospitals. There has been an increase in infrastructure. I cannot say that we, as a country, we have not increased our infrastructure. We have done for a country of our size and diversity and population, we have done fairly well in trying to increase our infrastructure, especially at the tertiary care level. However, our population increase has outstripped the increase in infrastructure, and our manpower shortfall is huge, which means health centers without resources, support staff, nursing staff, which is extremely important to deliver proper health. So like I said, the community health centers were our first tertiary level point of contact. So if as a surgeon, I should have been at a community health center sorting out things like acute appendicitis or a hernia or a acute scrotum, etc. And only big cases, say a renal transplant or a liver transplant, needs to be referred to a tertiary level hospital. It was supposed to require 4 specialists, a surgeon, a physician, a gynecologist, and a pediatrician. This was the minimum requirement of a community health center. Unfortunately, this didn't happen, and that's what we call the missing doctor syndrome. 82% of our posts are vacant. There's a shortfall of 87% of surgeons, 74% of OBGYNs, and again, physicians and pediatricians. And there are various reasons for this. And there is a tendency in our country to blame doctors for that, which is not really true. When a doctor goes to a place, he needs everything. Needs security, he needs a proper salary, he needs a place to stay, he needs a proper school for his children. His spouse might need another vocation or a job, which was not provided. It is fairly easy and fanciful to ask a doctor to go to a rural area or a community health center and work, but without giving that person facilities to take care of his or her life, it absolutely makes no sense and is illogical for people to work. And that's why a lot of our medical specialists are concentrated in larger cities where these facilities are available. This graph also shows how many district hospitals function with what they function. And so only 8% of our district hospitals, and these are 2017 figures, 8% of our district hospitals work with all 4 specialists, which is a big problem now. And only some of these states actually do well with all 4 specialists. A lot of those states are in the southern part of our country. Unfortunately, in the northern part of our country, we've done much worse when it comes to healthcare compared to the south. Going to the global scenario, this is another papers which came out in 2019. It's one of our most widely cited papers. We looked at the global burden of post-operative deaths, and you will be surprised to know that there are more deaths because of surgery than malaria, tuberculosis, and HIV combined across the world. This is a stark reality that a lot of us don't know about and a lot of us don't think about. While it probably is not right to classify diseases, but when it comes to research, there are some diseases which are popular with research and some which are not, and surgery, unfortunately, is not. Surgical deaths are the 3rd largest cause of death across the world after heart disease and stroke. The amount of research that has been done in cardiac disease and stroke has been huge. The amount of research that has been done in surgery has been pitiful. This paper was, it's one of the top 5% of cited papers across the world since it came out in terms of altimetric, and is available, I think, on the Lancet as a free access. So if you guys sometimes have time, go through this, because it sort of puts in perspective where surgery has failed to keep up with other specialties in terms of research and safe surgical care delivery. So that brings up that why is research in surgery necessary? It is critical, actually. 5 billion people, like the Lancet Commission said, have inadequate surgical care. There needs to be a massive growth in surgical infrastructure, especially in low and middle income countries. In India, we very easily talk about laparoscopic surgery and robotic surgery. If you go down to Africa, you probably still don't have in many countries, and I'm not talking cities, in many countries, the ability to do laparoscopic appendectomy, which sort of helps you avoid surgical site infections. So there needs to be a huge growth in surgical infrastructure. There needs to be a huge growth in practitioners of surgery. Surgery, when I started, when I finished my MBBS and was planning to do my post-graduation, was one of the most popular specialties to do. And if you were anybody, then you decided to do surgery. Unfortunately, if you look at the scenario now, nobody really wants to do surgery, which I don't blame anybody for that, because the opportunities that have been given for growth in surgery, especially in low and middle income countries, have been very little. There is a time for every physician and every surgeon when they want to be independent and do things on their own. Unfortunately, many countries have not been able to give that opportunity to our young surgeons. The risk, if we do not do this, is that we will overstretch resource. So a single surgeon managing more than 100,000 patients will lower standards of care. There will be mistakes, and there will be morbidity, and there will be mortality, increased patient harm, which will again take away the faith in surgery and in that surgeon. for no fault of him, his or hers, and people will have to travel longer distances to access surgical care. When I was training in Vellore, we used to get patients from the northeastern part of India and from Bengal to come they used to come down to Vellore, traveling 2 days on the train for a circumcision, which was astounding. And that was because there was a lack of faith rather than anything else. I don't think there was any lack of ability in the surgeons there. It's just the people had a lack of faith there. And I'm sure that was partly the reason was there were mistakes made, not by the surgeon, but then there is a lot that happens with surgery and after surgery, and in terms of how you deliver post-operative care, which needs additional staff. They needs nursing staff, support staff, etc. And so we used to get these patients who would wait for days on end to get a circumcision done and go home, which is fairly unfair on them, because many of them would be actually losing economic resources as well. They might be daily wage laborers, so they are actually losing salaries, wages coming down to Vellore to get a small surgery done. So it is necessary when we make plans that we have data behind that plans. If we do not have data and do not do research, then we make plans which are warped. And over the years in our country, since independence, unfortunate to say it, but a lot of our plans have been made without solid data backing them. And so those plans actually never work, and we waste a lot of time, money, energy, and enthusiasm on making those plans. Um, uh, there is when we do research, we try and assure quality surgical care. Every surgeon would want all of his patients to become well and be healthy members and contribute to society. And that is extremely important when you do surgery which has a certain amount of quality control. We try and engage the surgical community to improve patient outcomes. So as surgeons or people involved in surgical care are the people who should be driving patient outcomes rather than anybody else. And at the same time, we need to create future surgical leaders across the world, and especially in countries like ours. What we need today is surgical leaders. We were lucky to have good mentors. I'm not sure the surgical trainees of today, and many of you who will become surgical trainees soon, have enough good mentors in the country or even across the world. So what we can do, the first thing that needs to come, and like I said, is data and a lot of data, so that we know how to make sensible policy change. Those sensible policy change should be targeted towards improving delivery of surgical care, and as well improving delivery of safe surgical care. So there are two things to this, that we need to make sure that surgical care is delivered properly into our tier 2 cities, our tier 3 cities, and in our villages. And at the same time, that surgical care should be safe surgical care. There was a dictum that we were told by our teachers, is that if the first thing that we do as a surgeon, that you should not cause any harm. So if you're going to cause harm, then it's probably better not to do the surgery. And therefore, we need to decrease the adverse events, and that is the harm that comes out of surgery. Like I've said in my earlier slides, a lot of deaths across the world today happen because of post-operative complications. And that is an area where we need to target all our energies and research resources to improve care. This will automatically increase research output. At the same time, a lot of us need to start encouraging young surgeons. This doesn't happen very regularly. Unfortunately, surgery was always considered an apprenticeship. So you sat down and learned under the guru. Unfortunately, for many of our gurus, we continue to remain students throughout our life. So and never could really spread our own wings and become independent and fly on our own. And this is something that needs to change. It has changed massively in the West, but it needs to change in countries like ours. So our foundation, the Global Surge, first came up with some cohort studies, and Global Surge 1 looked at outcome of emergency abdominal surgery in high, middle, and low-income countries. And from there came out one of the seminal documents that we have in surgery, that is the WHO Surgical Safety Checklist. And then we looked at wound infection after gastrointestinal surgery worldwide in Global Surge 2, which is a cohort study that's about 7,500 patients across the world. We've divided that now into adult and pediatric cohorts. And in fact, a couple of days later at the pediatric surgery conference of the Indian Association, I will be speaking on the pediatric cohort of Global Surge 2. How we work, just a little bit about global surgery, how we work in what is called the hub and spoke model. We work in low and middle income countries according to the WHO definition of low and middle income countries. So hub is like the central administrative center of in a country, which sort of then coordinates with other sites, which we call spokes, and to deliver research projects and deliver research data, which is then again fed back to see whether there can be any change in policy. This was a simplistic model that we looked at, and when we started global surgery, and global surgery sort of really the collaborative really started in 2013, 14. We thought this will be fairly simple. Unfortunately, it wasn't, and since then we have grown into many other areas. We work mainly in Southern and Western Africa, and now recently in Sub-Saharan Africa, in Central America, and a few sites in Southern America, and in Ecuador and Peru. And in South Asia, we work in India, Pakistan, and in the Philippines. And we hope at some point of time we will move on to more of our, especially our South Asian neighbors in Bangladesh and in Nepal and in Sri Lanka, some of whom are taking part in one of our projects right now. India is a hub country, as we call it. It is one of the biggest hubs that now the Global Surge Research Collaborative has. The Global Surge Research Collaborative is sort of based in the University of Birmingham. It is funded by the National Institutes of Health Research and has inputs from the universities of Edinburgh and Warwick. But it does not mean that research is directed from the United Kingdom. The research goes the other way. The direction of research is from the hub countries, the low and middle income countries, which actually tell what the center of Birmingham needs to do. What Birmingham does for us is training and look at funding, etc. So it's a fairly democratic model. We sit across the table and discuss things as equals, rather than it is not a colonial model like some models can be, where the West dictates what research should be done in low and middle income countries. This doesn't happen with Global Surge. It is very difficult to dictate things to surgeons anywhere. One of our projects, last cohort study that we did with Global Surge, is called Global Surge 3, and we looked at the quality of cancer surgery worldwide. So our initial emphasis in terms of research was on surgical morbidity, especially surgical site infection, which is the biggest cause of morbidity. And surgical site infection actually account for 80% of postoperative morbidity, complications, and even deaths across the world. And then the other thing that we wanted to look at was cancer surgery. So Global Surge 3 was conducted in about 96 countries. There were a few centers from India, especially in Gujarat, etc., who collaborated on Global Surge 3, looking at 30-day mortality after cancer surgery. We have just submitted our first paper from Global Surge 3 into the Lancet, and we look forward to their commence soon. So about more than 15,000 patients were recruited into this study. From there, we moved on to what we call randomized control trials, and that is a higher level of research. And Falcon was our first randomized control trial, which was designed sitting together across the board in South Africa in 2016-17. We were supposed to run this trial till the middle of 2020, where we were going to randomize 5,000 patients. It's a 2x2 randomized trial. We were testing medicated sutures versus unmedicated sutures, and two different types of surgical preps to see whether they decrease surgical site infections. And that's where we talked about, that's where I want to talk about young people driving research. A lot of this research was driven by young surgical consultants, surgical trainees, not just in the UK, but in especially in India, in Africa. And a trial which was supposed to be finished, was supposed to finish in the middle of 2020, with the pandemic happening, finished about 15 months ahead of schedule. And we just closed out the trial in September this year. We were supposed to go on till, say, I think August, sorry, August 21, rather, not 2020, in August 21. And we closed 15 months ahead of schedule. And a lot of this was driven by young people, and not just surgeons or surgical trainees, by medical students and research associates. Um, I don't think many of us old people were really involved in driving this project. We should be coming out with our first papers in January. Right now, there's a cleaning of data and data analysis going on. There were 7 countries involved in it, 54 sites, which is one of the biggest randomized control trials in surgical site infections that has happened across the world. Um, Along with that, the pandemic came along and became an opportunity actually for many to do research, and we started doing modeling studies, and we looked at how surgery will be affected because of the pandemic. And this is something that we did in the beginning of the pandemic, especially in India in March, April. And we saw a model that about 28 and more than 28 million operations will be cancelled or postponed during what we naively thought was going to be 12 weeks of disruption because of the pandemic. Unfortunately, the pandemic is still on, and we have remodeled it to more than 80 million operations which will be cancelled, and this includes cancer operations, even at times obstetrical operations, leading to morbidity and long-term mortality. So a cancer surgery which would have been curative has suddenly become palliative, and there will be mortality associated with this. And this is across the board, not just in low and middle income countries, even in high income countries. And many of you working in your hospitals would realize that a lot of elective work has been cancelled or started and then again cancelled because of what the virus has done. We do different kinds of work. We also have I'm just going through some of the studies that we've done. Access is to look at why people are not able to come to surgical hospitals in time, or at times never. During my time after my pediatric surgery training, I used to travel at least 3-4 times a year to operate in various small hospitals across the country. Um, and the amount of work that is lying in the rural hospital is something that I would suggest all of you should go and access at some point in your career, to get to know the real India. When we sit in cities and big medical colleges, we do not realize what the real India is. And so we did this study where we interviewed patients, caregivers, doctors in rural hospitals, to see why people are not able to get access to surgical care. We're going to come out with our first publication or report out of this, which looks at the problem of transport when accessing surgical care, where people are in remote villages without roads and are not able to access a hospital which will be able to, say, do an appendectomy, for example. And so they will be in their villages with a perforated appendicitis, and they will die. They might not even get antibiotics there. So we did a systematic review of literature. We looked at interviews of patients and stakeholders, and we did economic modelings to see what we can do. And we're looking at a range of ambulance services in different settings. A few years back in CMC Ludhiana, we had started a motorcycle ambulance service. It was one of the first ones to be started in the country. And I think a lot of places have sort of replicated that. These are out-of-box solutions that need to be made in countries like ours, because many of our areas, not just in villages, even in our crowded cities, you will not be able to access patients with the regular ambulance. This is something that I'm extremely proud of. When we talk about research, and when I was a medical student or even a surgical trainee, when we talked about research, it was something that the professor did. The name of the professor came. It was all about the professor and nobody else. Abdominal tuberculosis or extrapulmonary tuberculosis is on the rise in our country, and we get a lot of surgical complications out of this. And it's one of our medical students who started looking at this and decided to do a study which was funded by the NIHR unit. The study is led by her, and it has been modeled by her. And we are just bystanders, looking very proudly at somebody who's not even a surgeon, but had an idea and has done a fair amount of work, and we hope to come out with papers on this extremely soon. So there's something that we call pump priming. We take small studies which are developed locally and which have local ideas and local needs, and we try and award some funding to run those studies. So Global Surge in India is already finished with Global Surge 3 and Falcon. Slide is slightly old. We are doing a cluster randomized trial. This is the first cluster randomized trial in surgery in the world. In this, we do not randomize patients. We randomize hospitals or operating rooms. Again, this is related to surgical site infections. We are doing CRANE, which is we're looking at local nutritional interventions to improve the level of malnutrition prior to cancer surgery. And we are right now in the trial phases of this project, and the main trial will be coming up. And I invite any of you who would like your hospitals to get involved in this and be part of this as and when it comes up. Access, we've just finished. I told you about the pump priming study, and we've done 2 COVID Surge studies, COVID Surge India, which looks at surgical outcomes in patients who had COVID and needed surgery, and COVID Surge Cancer, which looks at cancer outcomes in the times of the pandemic. We have some upcoming studies. Some of them are right now, we are close to taking more sites. Crocodile being looking at expenditure in colorectal cancer surgery. We are doing the pilot right now with 5 centers in India, and hopefully this will lead on to a bigger trial. And again, I would like to invite many of you to take part of this, not just in India, but across the world. Some of you, and I could see some names there who I recognize, are involved in COVID Surge Week. Extremely proud of what India has done for this particular study, because again, I think a lot of the study is being driven by medical students and interns. I have received messages of frustration from some of them because the consultants would not want to get involved, or would get involved and back out. I appreciate those, but that's part of the game. You will struggle a bit, but I'm very appreciative of the fact that a lot of you, both in my institution and in institutions across the country, are the people who are driving COVID Surge Week in India. We are going to be probably, if everything goes well, one of the highest recruiting countries in the world. We're just waiting for the Indian Council of Medical Research to give us approval for this, we hope to start this off as we've already started off and start uploading the data as and when it comes in. So COVID Surge Week has 77 hospitals in India. Already more than 160 teams have been registered for this. It is a huge undertaking that you guys have done. And everywhere it is being led by young people, young consultants, young researchers. And you have pushed us old 4Gs to actually get into this. And all of you, especially in India and across the world, should be very proud of yourselves for COVID Surge Week. Like Rohini said in the beginning, we also look at perioperative care. Penguin is a trial that we are doing on perioperative care, which relates to anesthesia and the delivery of oxygen during the surgery. We're looking at safe surgery, safe colorectal anastomosis, and developing a checklist for that. We are seeing whether hydroxychloroquine or the antivirals given prophylactically prevent complications of surgery in patients with COVID. And finally, you're looking at that drunk giraffe there. I'll talk about it a little bit more. And this is a study that we are going to start and develop in India. And again, this is something that you guys could be very, very intimately involved with. So what is remote in India? India is extremely diverse, and many of you would have visited these places. So you're looking at the Spiti Valley there on one side, and you're looking at the border of Bihar and Nepal on the other side. So remote in India does not signify one thing. It can be extremely, extremely different things across the world, across the country. And these are the places where we get data out for. A lot of our surgical papers in India come out of big institutes in bigger cities. But the real data is lying in our remote areas. And the real effect of surgical research in improving surgical care will happen in remote areas. Until we have the data from remote areas, we will not be able to make proper decisions. A decision made by somebody sitting in Ludhiana or in Delhi or Mumbai about how to deliver surgery does not work in the Spiti Valley. So that has to be local, and that is where we try to involve our people. So our research spokes are not just in Delhi and Mumbai or Chennai. They are not just in Ludhiana and Vellore. They are based in, say, Manali or say Raxol or Makunda, Nagaland, in the middle of UP, in the central part of India, in the Betul district, etc. And these are places where we try and develop spokes, develop research infrastructure, get ethical committees instituted, registered, so that they can deliver good, robust data which is ethical. So this is a picture of a beginning of last year when we started building the hub in India. This is the team, the surgical team from India and researchers who were developing the hub. And then we found out to develop spokes. So our people were trained, and you can see some of our research nurses and associates, then training doctors and surgeons. This particular picture has been taken in the border between Gujarat and Maharashtra. And we established spokes like this and research committees there. All research, if it only the only objective of the research is to publish a paper and get your name in a journal, is useless. Unless and until that research changes things, it's a waste of time. And therefore, it is very important that we have health economics. So a particular intervention, say Falcon, medicated sutures, might come out as useful. However, if it is too expensive for our population to access those, then it is pointless. So we try and build in health economics in all our studies to make sure that the final recommendations that we make are aligned with the economics of the area, of the country, of the city, so that it makes sense to change practice and get new interventions in to improve care. And if that is not there, it doesn't make any sense. So our key objectives, along with doing our research, is an economic analysis. Health economics is something which is coming up in a big way, and a lot of you might have done courses or studied about it. And we consider the opportunity cost when we decide to invest money. So as a government, if I'm asked to invest money on a particular intervention, it would make more sense to me as a policymaker to tell me how much, how effective that is going to be, and how much money it is going to save my people in the long run. So those are the key objectives of economic analysis: to efficiently use healthcare. We do not have a lot of money. It has to be used efficiently. There is not an endless supply of money for healthcare, because there are other objectives of a government. So with economic analysis, we will promote efficient use of healthcare resources and get maximum benefit with the resources that we have. So we would like to decide. So we would do talk a lot about in our country about cost effectiveness. We try to disentangle those terms. We take cost separately and effectiveness separately. So a particular intervention may be effective, but it might be too costly. So we look at both in a separate way and see whether we can match that. So we compare the costs and the outcomes of the intervention with the effectiveness of the intervention. Along with that, so that's health economics is now something that we have grown with over the past few years when we started developing global search work. So it started with just pure research and has moved on to health economics to improve, to give good policy statements. And along with that, now we have another thing that's coming out, which is community engagement and involvement. It's called CEI, and I would encourage you people to read about it, learn about it. A lot of us as doctors and scientists do research on what we think is right, which is not necessarily the case. It's like about parents and children. Parents think what is right for the children, but children might not think that is right for them. So what we try and do now before starting a research project is involve the community in developing the research project, whether that is going to be effective and needed by the community or not. If at the end of our everything, the project is not needed by the community, again, it's a waste of time. So we involve the patient and the public. So in many areas where there is, when we, like we did the Falcon trial, say in Northeast India, or the Cheetah trial, we talked to the community there and the community leaders, and there had to be a community consent for us to start the trial there. Now we want to go a step further back, where we will we try to engage with the community before starting the project, before even formulating, developing the project, to look at what the needs of the community are in terms of surgery. It can be used for other specialties as well. But for us, what are the needs that the community has for surgery, and what research will help us deliver those needs to the community? So CEI is an extremely important part of our portfolio now. We work on a corporate model. These are our publications which have come out since 2016. We work on a corporate model where it's not about Dhruv or it's not about Rohini. We are equal partners in research. The lead author is always the Global Research Collaborative. Everybody else's name, according to alphabetical order, is listed in an appendix. So it won't be that because Dhruv is a professor, so his name should go up in front, even though he's not done an iota of work. That doesn't work with us. For us, everybody, including our research nurses, our research associates, our data managers are important. And so are our medical students and interns and our junior consultants and our registrars. The whole point of Global Surge, especially Global Surge in India, is to deliver this model of research and planning finally over to our young surgical leaders in the coming I would say in the coming couple of years rather than few years. We are already looking at sort of Dhruv moving out and somebody younger taking over, because I personally feel that younger people have better ideas. They might not be practical ideas all the time, but they have the better ideas. And same with COVID Surge. These are some of our landmark papers that have come out recently in COVID Surge. And last week we published in the Journal of Clinical Oncology on cancer surgery in COVID Surge, looking at surgical pathways, hot and cold systems, etc. I told you about COVID Surge Week. Unfortunately, we have closed out taking any more centers into COVID Surge Week now because of our application, which has gone into the ICMR. But again, I'm very thankful to the people who have taken part in this. The fourth important component of our research collaborative is training. It is our vision to train the next generation of surgeons, scientists, and research managers. So when I say surgeon scientist, so as a surgeon, you could be a scientist, but you don't have to be a surgeon to be a research manager. We provide tailored, and especially before the pandemic, we used to provide tailored training for unit studies, on-site, hands-on training, video conferencing, online modules. We also provide degree courses, online degree courses, an MS in surgery or a CHM in various aspects of surgery through the University of Edinburgh, and some of them have scholarships. Or we can give you options on what kind of scholarships you can access. Because for many in our countries, the cost might be prohibited. So we do offer some scholarships on those courses, and one of our young surgeons in Ludhiana is doing one of those courses right now. So I've already talked about this on what we do. We also we have made guidelines of how to prevent surgical site infections as well as surgery during COVID times. These guidelines have also been made. And then finally, the drunk giraffe. This is a project we are looking at now because we've already looked at, say, surgical site infections, so intraoperative, perioperative. But what happens post-operatively in the wards? And some of you who have worked in the wards and as interns or even medical students would realize, you would have seen in India, suddenly a patient in the ward has become sick and is being rushed to the ICU. That is morbidity and actually can lead to mortality. So what we are looking at, seeing whether we can decrease that by having a training package which is delivered online on your mobile phones or your iPads or even on the computer, to train you in various aspects of post-operative care. So it's for it was initially thought to be for junior doctors, junior consultants, or ward nurses, and we're now trying to expand that to interns as well. Some of you must have looked at something like the Harriet Lane Handbook. If you worked in pediatrics, it is something similar, but will have text, videos, chats, and good papers, which will give you evidence. And this is something that we are developing right now. This will be led by researchers in India. It will be developed in India. And as and when it develops, I welcome you to be a part of Giraffe. You would notice that most of our projects have an animal-based theme. It was not by design, it's just happened that way. So when we started in April 2019, we had about 6 centers. I'm sorry if you're not able to see the blue thumbtacks, but we had 6 centers in April 2019. You could make out the paucity of research that is done in surgery in our country, and even in big hospitals like mine. And the amount of interest that is there to want to do something, but people did not have an outlet. And Global Surge, fortunately, was able to provide some sort of an outlet. So this is what the map looked like in April 2019. This is what the map looks like now, which is like 1.5 years later. These are the number of centers which are doing research. There are big hospitals, tertiary hospitals like the various All India institutes in Vellore and Ludhiana, medical colleges across the country. Then there are smaller district hospitals, and there are rural hospitals also. So there has been a huge amount of interest, especially from young people, and which has sort of driven Global Surge accordingly. Looking ahead, it is becoming difficult for us to develop, to sort of manage everything from Ludhiana. So we are sort of going to divide the country into 4 zones and have sub-hubs at the All India Institute in Jodhpur, at the Tata Medical Center in Calcutta and in Vellore. So we can access more areas, we can involve more people and give you data like never before, and so influence policy change. We invite ideas from everybody, medical students, interns, non-medical students, everybody, in setting up both not just research infrastructure in terms of research ideas, then we will look at how we can fund those research ideas. We are planning a formalized program in training and education, so a PhD and an MSc in global surgery, and a PhD in health economics. Recently, we have been in talks with the Public Health Foundation of India, as well as the London School of Economics, in developing PhD programs, which will run from India. And this is an opportunity for some of you who would like to be researchers rather than clinicians to get involved in this. And finally, we are now looking at evolving a rural surgery research network, which will be based in a rural hospital and will drive change in rural surgery practice. This is finally what we want from our surgical research in our country. Happy parents, happy children, happy patients. And thank you very much for letting me talk. I hope I haven't overshot my time too much. And I hope everybody's not gone off to sleep. I would have.
Not at all, sir. Thank you so much for taking out your time. It was a very interesting presentation, very informative, and I'm sure very inspiring for everyone, because now we have a lot of questions that everyone's been asking in the chat. And the main question, the first question is that I also had in the beginning when I started approaching regarding surgical research is, how do we approach surgeons? Because it's very common amongst Indian surgeons that they shoo away medical students. They don't want to involve students in research. So how can a student convince and persuade them?
Yeah, I think all of us as surgeons at some point of time have been guilty of that. And I would count myself amongst one of the guilty people. I think I'm not really sure about that answer, really. Surgeons are a difficult breed of people. And speaking as a surgeon myself, we are a bit full of ourselves. I hope it changes with young people, and the way we want to go about it is to try and change junior surgeons not to become like us. what you could probably do is, Rohini, you know our contacts, and if anybody wants to get in touch and is having a problem in his or her hospital in terms of approaching a senior surgeon, something that maybe you could contact us and we could try and talk to them. Probably they would probably listen to us if they are not listening to you. However, some medical students are persistent, and that is a very good quality. Rohini is a persistent woman, and so that is the one quality you should develop if you are a researcher. You have to be persistent. You will get through. I remember when I was in school, I used to I read a book by author called Jack London, and he used to say that you keep knocking on the walls with your hands, and one day it'll break. So you have to keep knocking. It can be difficult, and it's not just in India, it's across the world. It is like that. Surgeons are a difficult breed of people, and some of us are really, really bad. But it is not something that is with this country. It's just a culture which has been developed over many centuries, and it's not going to change overnight. Even in the West, it has taken ages to change. In our country, we still work with a lot of colonial mindsets. A lot of our medical education is built on the British system of medical education. The British have changed. We have hung on to it, and so it can be very difficult. So if you are having a problem, do let us know. We will try and see whether we can fix it. We're not promising that we will be successful. If there's a person that a surgeon doesn't want to listen to, it's another surgeon. So so you might be successful more than us, but we will try and help you. But frankly, an out and out answer, I don't have one really.
I think additionally, I would like to add that as a medical student, you should be very clear with your intentions when you're approaching a surgeon. So I actually wrote a letter of intent telling sir and the other teachers at the hub why I am interested in global surgery, what are my long-term goals, what are my short-term goals. And I sent them my CV, even though they didn't ask for it, so they can see from my past experiences that I am someone who is dedicated and that they can trust. And then it takes some time to build that trust. And I'm still working on building that trust with sir so I can get more research opportunities in the future. So I
Yeah,
think
Really, you're right. Sorry, I'm interrupting you there because and the fault lies on both sides. Really, there are some medical students who will come to, and some of them have come to me also. They want to do research, and we get down to a topic and we do some work, and I do some work, and then I don't see that person ever again. So that sort of breaks the trust. So that probably from your side as younger people, that trust needs to be continued. You have to. It's not easy to do research. It can be boring at times, but if you give up, then nothing's going to come out of it. So you're right there that your intent has to be very clear and very true on what you're going to do and how you're going to perform.
yeah. So everyone is basically asking how they can get involved in research as a medical student. For that, I would suggest MRSA, that is the Medical Education and Research Society of AMSA India. It was just launched last month. We have a MRSA methodologies workshop coming up next week for everyone who's interested on how to start research projects. And that is how you basically get involved in basic research as a medical student. Then people have questions about how they can get involved in our projects. So I guess they could, if it's a medical student, they can email me and they can email you, and then we can see how we can approach their faculty for them.
I would ask them to email Rohini or our email ID in for Global Surgery in India, which is Global Surgery India, Global Surge India at cmcludhiana.in, which Rohini could give to you. You could email me. I have absolutely no problem. If I don't answer, I might have missed the mail, so please email me again. I'm very happy to put you in touch with, especially some of our upcoming projects where we will be still taking people in to take part in it.
Yes, sir. I think that's it. And I think everyone should be looking forward to the giraffe RCT, because the introduction of the giraffe RCT, when it happened, that's when I found out about the global surgery hub in particular, that there is something like that in my college. Because at first I would just see posters of Falcon RCT in the OT and I had no clue what it was about. So the global surgery hub and the giraffe RCT that's coming up, that's focused on improving surgical education. And what better than us medical students to decide the kind of education we deserve?
Yeah, I think Giraffe, what we've done with Giraffe, we've actually taken advice from medical students and interns of what they want to learn. again, this is you are the stakeholders there, so it is important that stakeholders are involved in it. My advice to you, at the end of the day, the patient is in the middle of everything. This is he or she is the reason why we are doing that. Please don't do research for yourselves. Do research for improving patients' care more than anything else. We have to be very ethical about that. While it's nice to have a lot of papers and a good CV, if you have not made a difference, it's a waste of time.
Absolutely. Are there any more questions for Sir?
I hope not, because I was a backbencher in medical school and do not like questions.
Are you in collaboration with any of the medical colleges in the state of UP?
In the state of UP, we are working with the King George Medical University. We had, there is a medical college in Orai, which had emailed us for COVID Surge Week, but we have not really heard from them back. But KGMU, yes, we are intimately involved with them in quite a few projects. So if there's anybody else, Bangalore medical colleges, no. Hospitals, yes. So we are with the Mazumdar Shaw Cancer Center, Kidwai, some of the other hospitals in Bangalore, but not the medical colleges. Mumbai, yes. A lot of hospitals in Karnataka, yes, but not medical colleges. No, not in Mysore. Ooh, Sikkim, no. Would love to be involved with somebody in Sikkim. Beautiful part of the world. Chennai, so in Chennai, we are not really involved with, so the nearest place in Chennai, in Tamil Nadu, we have is Vellore, but we would be very happy for you to email us and we would get involved. Varda, there is a medical college in Savangi, Jawaharlal Nehru Medical College, which is involved with us. Not in Nagpur. Gandhinagar, no. Ahmedabad, yes. Hyderabad, yes. We have the Children's Hospital, Rainbow Children's Hospital, which is with us. Rajasthan, AIMS Jodhpur, you saw. Jaipur, there's a hospital which is involved with us. Kerala medical colleges. Let me get that. Yes, there are a couple of medical colleges in Kerala which are involved with us. Medical College Trivandrum, they are involved with us, and there's another medical college in Kerala who's involved. I'm not getting the name. I'm sorry. Mangalore, Manipal is involved with us in quite a few projects. Kolkata, yes, Institute of Neurosciences. I can make out a lot of people from Kerala. I'd be very happy to involve anybody from Kerala. My wife is from Kerala, so I cannot say no. Uttarakhand, AIMS Rishikesh is involved with us. Please, if you are from Uttarakhand, I have a soft spot. I come from Dehradun. So I have been trying to get more people in Uttarakhand involved. So if you are interested, please call me from Uttarakhand. Delhi, yes, AIMS Delhi, Safdarjung. These are two of the bigger centers. St. Stephen's Hospital, who are involved with us in our projects. Maharashtra, yes. Kolkata, like I told you, Tamil Nadu, Vellore is involved with us, but we'll be happy to have more people from Tamil Nadu there. Jaipur, like I said, Jaipur is your Santokh Durlabh something hospital. It's an ophthalmology hospital. Madhya Pradesh, we have Padar in Betul district and AIMS Bhopal, which is involved with us. Yep, Mangalore, I just said Manipal. Yep.
Okay. So
I can give Rohini a list of hospitals who are involved with us, and she can pass it on. If you are in one of those hospitals, please. Yeah, I'll do that. So Malika, I'll send a list over to you sometime this evening, or just remind me, Rohini. I've become old, nearing Alzheimer's now.
Yes, sir, I'll remind you. And we can also set up a Google form maybe for all AMSA India members who are interested. So we have it in a spreadsheet format, and we can help people out systematically to get involved with future projects.
Akshay has asked, Akshay, can you just email us? The email address Rohini will be able to give you, and we will get you involved and keep you there, keep you with us.
Yes, sir.
Okay.
Okay. Thank you so much, sir, for taking out the time.
Thank you so much. Thank you for having me.
Us.
Yeah. Okay, bye.
Thank you so much. Thank you, everyone, for being such a great audience.
Okay, Rohini, I'm so sorry to interrupt you in between. Now, guys, before we end, we have a question for the host, Rohini. Now, Rohini mentioned in the beginning during her introduction that she is a researcher at NIHR. Now, for people who don't know what NIHR stands for, it stands for the National Institute for Health Research. So now we would like to request Rohini to throw some more light in her involvement in global surgery research. How has been her experience so far, and would she like to give us some pointers, and would you like to give us some steps about how can we be involved from a point of view from a fellow researcher's point of view from a fellow student itself? Thank you in advance, Rohini.
Thank you for putting me on the spot like that. I'll make it quick because I actually have a crocodile meeting to go to at 3 and I'm already late for it. So like I said, I first wanted to take part in research primarily because I want to give step one. I want to improve my CV. But then when I got into ICMR STS, I realized the impact of that research can have, and it's more than just a publication. And my interest in OBGYN led me towards global surgery research. As I told you, Dr. Dimitri, he came from Birmingham to address us regarding the giraffe RCT. And the fact that they were telling us that we could be involved in deciding what we learn, that was like amazing for me, because that's what research should truly be about, right? That we are developing data to improve what we want and not just for a citation. So that's when I became involved with global surgery unit. Like sir said, it's not easy. I persisted for around 2 months on and off, asking to be involved in one project or the other. Brought my ideas, they brought ideas, and then they finally accepted me as one of their own. I hope they have. So currently I'm taking part in multiple projects. The project that you saw, Cheetah RCT, so it has sub trials. So I'm taking part in Talon and Kiwi. Kiwi is a health economic trial under Cheetah to see the financial burden that patients face when they come for OPD visits after surgery. And Talon is to see wound infections via video calls and telephonically, especially during the pandemic. That's been helping a lot. Then I'm involved in the Global Surgery and COVID Surge Week, phase 2, which starts tomorrow. And at the same time, I'm involved in something that is not part of this study, a part of this network, but it's a global child NCDs network where they're assessing pediatric cancer services during the pandemic. Not part of NIHR surgery, a different type of surgical collaborative. And something new that I'm really excited about that is happening is the crocodile study. That's to assess catastrophic expenditure in colorectal cancer patients and their care. So how I persisted, sir, basically the tips is what I already said. Be persistent, be very clear with your intentions. At least in my college, I saw the experience of surgeons and why they're reluctant to take students is because a lot of students, like sir said, they come and go. They come with an idea, sir helps them, sir looks forward to them coming back, but then they just disappear. And if you're not serious about research, and there's no need for you to come in this field because it requires a lot of seriousness, a lot of persistence, and a lot of hard work. And it can be boring also. So right now I'm doing Kiwi follow-ups. I get called half an hour before the patient comes to the OPD, and I just have to fill a form and talk to patients. It's not very interesting, but it's important. You have to understand that your small role can play a huge impact in something big, in transforming a change. So you shouldn't I would say think very minutely of yourself when you're involved in research. That's really important to keep yourself going. And if no one has asked you, still provide your CV, know how to talk about yourself, know how to brand yourself in front of surgeons. If you've done things in AMSA, they will be appreciative of the fact that you've led things in student organizations. If you have previous researchers, even though they were small like the ICM or STS, it's a great beginning, a great foundational stone to give to your consultants and tell them that, hey, I've done this, now I want to learn this, so please help me. And there's no reason why they'll say no otherwise. So I think that's basically it. Yeah.
Thank you so much, Rohini. And I think we all have learned so much from this small 5 minutes talk that you just gave us. And we really appreciate that. So thank you so much, Rohini, for joining us. I think you're running late, but before that, can you just ping in your email in the chat box, as many people are requesting for that?
Sure, why not? So my email is rodatta08@gmail.com. And my Instagram is Beyond Her Curls. _. I'm more active on Instagram, so if you DM me there, you will get a response much more quickly. And if you want my Twitter, where I share a lot of global surgery related things, it's Rodatta. Yeah, that's it. Thank you so much for this impromptu session, Malika. But I really have to go now.
Okay, thank you so much, Rohini. And guys, Khushman is right. Do follow her for a lot of inspiration. She is an influencer herself.
I'm
And
not
guys,
an
now,
influencer. I'm not an influencer. Please. I love you too, Kushman. Okay, bye.
bye, Rohini. Okay, guys, so now the time which many of you were waiting for, we'll now be displaying the QR code for you to scan. For everyone in the Zoom meeting as well as watching it on YouTube, you can scan this QR code, which will lead you to the delegate form for you to fill to mark your attendance. Also, the sign-in picture for the same, we request you to use our filters that we have designed. But in case you're unable to do that, you can click a picture of the session and upload that. So here is the picture, and exactly at 3:20, I'll close the session. Thank you so much for joining us. This was a session with Dr. Dhruv Ghosh and host Dr. Rohini Datta, and the theme being Indian scenario of global surgery research and how medical students can get involved. Please scan this QR code, which is present on your screen, to mark your attendance. In case you're unable to scan it, in case you're having any problems, you can always contact your group moderators. They will guide you. In case you want the link to the form, you please contact your group moderators. They will help you in that. But the QR code itself will lead you to the link. I am sending the email accounts of Sir as well as Rohini in the chat. So in case you are this is Rohini's. Guys, we repeat again, people who are asking us for the link, we request you to please contact your group moderators. They have the link for the same and they will send it to you. Yes, those who have submitted the attendance, that is those who have filled the form, are free to leave.